Hello everyone, this presentation will cover dilated cardiomyopathy and a case study of a patient named Romeo affected by this disease. This disease can be devastating and must be treated aggressively. As technicians, it is important for us to understand and recognize the signs in order to reach a treatment therapy as quickly as possible. We will cover some common signs and diagnostics, prognosis, and options for therapy, and then to conclude, we will apply the information we learn into a case study. Dilated cardiomyopathy is the condition where the heart muscle degenerates. This degeneration is caused by increased blood pressure within the heart, which stretches the myocardium to become thin, and most particularly of the left ventricle. The top image is normal wall thickness and shape of the myocardium. The bottom image highlights the thin walls described as dilated cardiomyopathy. The cause is unknown, although it is likely familial inheritance of genetic mutations or the result of myocardial insults. There are two phases, the asymptomatic and the symptomatic. The asymptomatic phase is known to last up to 4 years in Doberman pinschers, and the symptomatic phase is typically at that point of rapid progression. Primary DCM is inherited and noted in these breeds: Doberman pinschers, Great Danes, Boxers, Newfoundlands, Irish Wolfhounds, American Cocker Spaniels, and Standard Schnauzers. Secondary DCM can be the cause of drug exposure, an infectious agent, taurine deficiency, or persistent sustained tachycardia. The wide range of clinical signs is a result of the two phases. Patients can present asymptomatically or experience sudden death. So you can see all levels from between when patients present to your clinic. What you want to look out for on presentation is coughing, dyspnea, exercise intolerance, and ascites. The picture here on to the right is a canine patient with ascites, or the accumulation of fluid in the abdomen due to right-sided DCM. A low-pitched gallop rhythm is common with DCM, however, a soft systolic murmur can also present with this disease. You can find the systolic murmur with the stethoscope bell near the apex of the heart. High blood pressure in the left ventricle is the cause of the stretching of the myocardium. Therefore, obtaining multiple consecutive blood pressure readings is ideal for the disease progression documentation. Since the heart muscle is now stretched, we should expect to see hypotension due to the decrease of cardiac output. We're going to listen to two audio files. The first is to achieve the baseline for a normal canine heart rhythm, and the second describes the gallop rhythm.
So what we normally hear are S1 and S2 in a normal animal. Whoop, boom, whoop, boom, whoop, boom, whoop, boom.
And again, here's the gallop sound.
We hear a gallop sound, which is whoop, boom, boom, whoop, boom, boom, whoop, boom, boom, 1, 2, 3, 1, 2, 3, whoop, boom, boom, whoop, boom, boom, whoop, boom, boom.
There are a few irregular rhythms to look for: VPCs, premature atrial complexes, ventricular or supraventricular tachycardia, and atrial fibrillation. DCM may result in pulse deficits, so make a habit to palpate pulses during your auscultation. Other presentation signs to look for include, in right-sided congestive heart failure, is distended jugular veins, jugular pulsation, ascites, hepatomegaly, and muffled heart sounds and lung sounds due to pleural effusion. For left-sided, we're going to hear harsh lung sounds, crackles, or pulmonary edema. The first video we're going to listen to is fine crackle lung sounds caused by pulmonary edema, something we might see in the left-sided congestive heart failure. second video is of coarse crackles. Initial diagnostics should include blood pressure measurement, pulse oximetry, and ECG, followed by CBC chem, thoracic radiographs, and urinalysis. Echocardiography uses ultrasound and Doppler and are often a specialty diagnostic exam requested and referred out by the attending veterinarian. On the chemistry panel, we are looking for mild increases in BUN, creatinine, and alkaline phosphate levels. We may see blood and plasma taurine concentrations with Cocker Spaniels or any other atypical breed. The CBC is typically unremarkable, however we may see elevated WBCs. Urinalysis is also typically unremarkable, but may reveal other underlying issues. Although CBC and urinalysis results are typically unremarkable, they can be useful in determining underlying issues and route of therapy. Some highlights to look for are WBC count, BUN, and creatinine levels. These two images are myocardial samples. The left is normal tissue and the right is dilated cardiomyopathy tissue. Note the widened interstitial area with the increased amounts of cells on this arrow. Obtaining an ECG is one of the first diagnostic procedures we should obtain on every patient upon physical exam. Routine collection of ECGs for DCM patients will reveal patterns which assist with determining responses to therapy. The diagrams here depicted are examples of arrhythmias seen in DCM patients. The first is a VPC, or premature ventricular complex, here. The second is a premature atrial contraction followed by a normal heartbeat. The bottom photo is of ventricular tachycardia. Radiology is a key component to diagnosis with these patients, which usually have a significantly enlarged heart, but not always. Thoracic radiographs assist the evaluation of the cardiac silhouette and evidence of CHF. The left-sided CHF is common in Dobermans and Boxers, while a generalized cardiomegaly is common for all large and giant breeds. The main factors we're looking for are left atrial enlargement, pulmonary venous distension, and an interstitial to alveolar lung pattern. We should also give attention to checking the pulmonary function for non-cardiac pulmonary edema secondary to heart enlargement. The first image here shows a moderate example of pleural effusion, with the arrow depicting the fissure line, a possibility we might see in right-sided congestive heart failure. The second image is a dorsal ventral thoracic radiograph with pulmonary edema. Note the alveolar interstitial pattern in the lung fields and the cardiomegaly with a straightened caudal border. So we lose that sharpened apex of the heart that we normally see. It becomes more rounded, as in this picture. An echo is required for definitive diagnosis of DCM. Using two-dimensional M-mode and Doppler methods, we can characterize chamber enlargement, determine systolic function, and detect the presence of severity of valvular insufficiency. This 2D image here is the left atria and ventricle enlarged. The arrow is facing the VPC recorded at the time. Here's the VPC, here's your atria, here's your ventricle. The top photo here is an M mode of an echo. The cavity shown here is the left ventricle with measurements of end systole and end diastole. Here they are increased measurements indicating systolic dysfunction and end diastole volume overloading. The colorful Doppler seen in the bottom photo demonstrates mitral valve regurgitation in a dog with dilated cardiomyopathy. So the colorful section here is your regurg. Volume overloading associated with dilated cardiomyopathy can result in distension of the annulus of the atrioventricular valve, leading to regurgitation. Unfortunately, the primary phase of this disease is always fatal with a poor prognosis. Indication of later stages of DCM are pulmonary edema, pleural effusion, ascites, atrial fibrillation, and onset of the disease at a younger age. Secondary DCM by taurine deficiency and sustained tachycardia are potentially reversible. It is important to understand that the purpose of any therapy is to delay onset. Obtaining serial blood gas and pulse oximetry have been practiced to monitor responses to therapy. A common therapy for occult or the asymptomatic DCM in Dobermans includes pimobendan and angiotensin-converting enzyme inhibitors. For symptomatic DCM, we reach to palliative care of the clinical signs. Our goal here is to improve quality of life. What that may include is antiarrhythmias and positive inotropes such as pimobendan. Positive inotropes increase the strength muscle contractions, increasing stroke volume and therefore cardiac output. Periodic abdominocentesis for profound ascites during respiratory distress is an option for therapy. Also, the use of IV inotropes for cases with severe hypotension, rate control, and atrial fibrillations are sometimes used. Chronic therapy options include the addition of furosemide, angiotensin-converting enzyme inhibitors, and positive inotropes. Finally, we are going to take everything that we learned and apply it to a case study. This is Romeo. He is a 96.3 pound, 7-year-old neutered male Great Dane mixed breed dog. He was adopted from a shelter 5 years ago and has had no previous health issues. He receives weight-appropriate doses of Heartgard monthly and Brevecto every 3 months. His current diet is Purina Pro Plan, the large breed adult, and is not grain-free. Romeo is an active dog, going on mile-long walks a few times a week and playing with other dogs in the home. Recently, he has been more tired during walks. The owner reported a progressive decline in general mentation and appearance over in the last 3 months. Romeo became exercise intolerant, lethargic at times, lost a significant amount of weight, experienced a decreased appetite, and developed an occasional cough during the day. Think of the must-have diagnostics we went over that you would obtain during your physical exam. So, auscultation of the heart and lungs, ECG, peripheral pulse palpation, CRT, and pulse oximetry. Upon presentation, the veterinarian noted that he had an increased resting heart and respiratory rates, a murmur, and a gallop rhythm. Romeo appears to exhibit signs of cachexia, the muscle wasting and generalized weakness, and the veterinarian then ordered a CBC chem, urinalysis, radiographs, and ECG. So what are you expecting to find on Romeo's physical exam? Depressed mentation was found, a high normal temp, pale mucous membranes, and a greater than 2-second CRT. Romeo had a resting 140 BPM heart rate with a grade 3 out of 6 left-sided systolic heart murmur. Crackles were also auscultated on the lungs at a 35 respirations per minute. A systolic heart murmur is the whoosh between the S1 and S2 beats. Here's an audio where you will hear the beat whoosh beat pattern.
S2. So what we hear is
Here are 2 pictures of Romeo. The top was taken 5 months prior to his DCM diagnosis, and he looks fairly normal weight, size. The bottom features Romeo with a sunken-in appearance. Notice his prominent skull bones on the top and around his eyes and jawline. This is how quickly the symptomatic phase can occur. Before we reveal the results, can anyone guess as to what we should expect? So here's what we found on Romeo. To start, the WBC count, neutrophils, and monocytes are marked high. Here's your WBC, neutrophils, and monocytes. This is normally something on the CBC that would be unremarkable, but it seems as though Romeo is experiencing an infection. Platelets are also mildly low and basophils are slightly high. So your basophils are here and your platelets are here. And as we can recall, mild increases can be found in creatinine and BUN, and Romeo's results were both high. Here's creatinine and BUN. Does anyone remember what to expect on a urinalysis? We are expecting an unremarkable urinalysis, typical with DCM. However, urinalysis results for Romeo revealed a high white blood cell count. A ventral dorsal thoracic radiograph was the only one taken for Romeo, and before I reveal the radiograph, try to recall some of the common symptoms we're looking for. The indicator here was the rounded anatomy of his heart, although difficult to see. Pulmonary edema was suspected based on the auscultation of crackles during the physical exam. For comparison purpose, here's the radiograph from earlier in the lecture to compare to. Remember, the example radiograph is a rounded heart anatomy. There isn't a distinct apex of the heart, and there is a clear pulmonary edema shown. An estimate of 6 months was given for therapy with the following regimen: pimobendan, furosemide, and sotalol. Ultimately, humane euthanasia was chosen near the estimated therapy time frame. In summary, DCM is a fatal disease most commonly caused by high blood pressure, thinning of the walls of the myocardium. We recognize this disease first by the common signs of muscle wasting, loss of appetite, exercise intolerance, and ascites. Routine diagnostics will almost always include CBC Chem, UA, ECG, and thoracic radiographs, and echo for definitive diagnosis. Whether inherited or secondary to drugs, infection, or taurine deficiency, therapy and treatment will have similar goals: to delay onset and improve quality of life. Thank you guys for joining. We hope that this presentation built upon your knowledge of dilated cardiomyopathy so that when it presents to you in your clinic, you might more easily find your therapy and help your veterinarian find a diagnosis.